All right, good morning. Well, Dr. Wells and I have the distinct pleasure of co-chairing the Colorado Substance Exposed Newborn Steering Committee. The steering committee is a partnership of, it's chaired by the Colorado Attorney General, and it represents multiple different disciplines. Was founded in 2006. The Substance Abuse Task Force was founded in 2006. Kathi and I formed the steering committee in 2008. The current structure of the steering committee includes a large steering committee, a family advisory board, and 6 work groups. I'm going to talk through all of these at the end, but wanted to just kind of give you this frame as where we're coming today is really to represent this work. So Dr. Wells is going to talk us through the work that we've done to get here today and the work on plans of safe care. But first I wanted to just quickly provide the frame of when we started this work together in 2008. We were really intentional to look at what's called the 5 points of intervention. So this comes out of the National Center on Substance Abuse and Child Welfare. And when we started this work, it was actually a linear process. And it started with pre-pregnancy and went through prenatal, birth, postnatal, and throughout childhood. And as we started to do this work, it became very clear to us that this actually isn't a linear process, it's a cycle. Because once we hit childhood, that's our kind of next generation of kiddos that are in the pre-pregnancy phase as we start to get into preconception work. So the work of the steering committee and the work that we'll talk about today is really intentionally oriented around these 5 points of intervention, and we'll spend time this morning kind of calling out different opportunities within this cycle to really do prevention and intervention work. With that, I'll turn it over to Dr. Wells.
Well, good morning. It really is a pleasure to be here. You know, Jade and I have spent a lot of years working together, and we have had the opportunity to really work with a lot of folks around the state and learn from all of you. And so one of the things that I enjoy the most about these kinds of opportunities is the ability to learn from each other. And so as Lucinda said earlier, actually I'm going to create a little bit greater challenge for you than she did. I think that at the end of the day, I'm hoping that you all will go back and not just talk to your friends and families, but become ambassadors for what we're going to share with you around a challenging issue, and an issue that, to be frankly honest with you, I hope we can give each other and ourselves some grace in the work in this field. And let me explain that a little more, because I think one of the things begins with learning where we have grown individually in doing this work and how we get to challenge each other to grow even more. And so to me, an opportunity to have all of you here representing the healthcare community, representing child welfare, representing substance use treatment and other community partners, I think is huge. You might ask, why is a child abuse pediatrician up there talking about this issue? And some of you might really get it and say, this is child abuse. And some of you might say, well, wait a second, this is a disease that impacts families and we need to treat it as such. And that's the journey we're going to take you on, okay? And I want to start this, and I know Lucinda asked a little bit, but let me ask something in a different way. How many of you yourselves or have worked in an organization or currently work in an organization that does things like develops discharge plans for babies out of hospitals that may have been prenatally exposed to substances? Okay? How many of you have provided prenatal care in the healthcare setting to someone who may have a substance use disorder or does have a substance use disorder? Okay? How many of you have received, or your agencies have received, referrals regarding someone who might be at risk of or has abused their child? Okay. Do you all see why there might be an opportunity for some conflicting feelings about this field? Okay. I will tell you my very brief story. As a general pediatrician in a small community, some of you may have heard this, but the reason I tell this is not to talk about me, but it's to say that we all get to hold up our own experience in a way that says, I have learned and I have changed because I've been challenged by this work together. Okay. I had a little baby named Christina that was brought in by her aunt because shortly after she was born in the emergency department to a mom who did not know she was pregnant and had a history of substance use disorder. This was not in Colorado. This was about 20 years ago. And I can really still see her face. And her aunt found out she was an aunt. She was paternal aunt. And said, hey, I can help with her whenever you need. And mom, who was struggling with her substance use disorder, pretty quickly started to say, you know, can you watch her? And when she would say she was going to take her back, she would say, you know what, I can't do it right now. And all of a sudden I had on my doorstep as a young pediatrician, a little baby who had a medical issue, a heart defect, who was prenatally exposed, and a situation which I had no clue how to handle. Okay, what I knew was my job was to address her medical needs and then also find out who could provide appropriate care for her and who can actually consent to treatment. Has anybody ever heard those kinds of challenges, right? It was a really complex issue. And as a young pediatrician, my thought was, honestly, she needs someone who can care for her and love her and provide safety and ongoing care as she grows out older. And I will be honest, when I started this work, it was hard for me to see that in someone who had delivered a baby, gotten no prenatal care, and essentially handed her off to somebody else who she didn't even know to care for, okay? I've changed because I've met a lot of people along our path together that have helped me understand this differently. And so while I even entered this as understanding this is a healthcare issue from a public health lens, I still struggled on this journey. And the other way I want to sort of frame this for you all as we start this work together is to say, how many of you have provided care or worked with families in that pre-pregnancy phase? So someone who does not have children, is not yet pregnant, but may be of the age they're somehow going to be pregnant. Okay? I would suggest that probably more of you have done that, but bear with me. How many of you have ever worked with a child or a family when mom is pregnant? Okay. How many of you have worked with or are working with someone who has a newborn baby? Okay. How many of you are working with a family or a child that is in young years, in the first couple of years of life, in a very formative phase in terms of their development and growth? Okay. And how many of you are working with or have worked with someone who is in the adolescent phase, who is now potentially going to be our next parents? Okay. How many of you want what's best for kids and families in the state of Colorado? Okay. So you know what? We're not all that different, and we have a real opportunity to be ambassadors for this work in a really complicated area. Okay. So my next question is, how many of you before today or before your invitation here heard the words Child Abuse Prevention and Treatment Act, or CAPTA? Okay, so some of you were like me, and I had no clue. All I knew is I had a little baby named Christina in my office that needed care, okay? And I embarked on this journey in the late 90s before CAPTA was reauthorized, and you're going to hear a little bit more about CAPTA. And what I mean by that is there is a, and you all, by the way, we've all become really good friends, okay, in terms of my work with child welfare and other folks that work in this field. And they correct me sometimes when I get this wrong, but from my very pediatrician lens, although someone who has worked in this field for a while, I will tell you that CAPTA is this federal act, so it's the federal government that has requirements of states and child welfare agencies to do certain things in order to continue to receive resources to prevent and treat child abuse and neglect. How did I do?
Pretty good.
All right, okay. So the reality is back in 03, okay, actually in 03, and then it was amended in 2010, CAPTA, the authorization, was really talking about what do we do with these families where there is a baby that was exposed prenatally to substances in utero? And how do we manage this very complex issue from a child welfare standpoint? Okay, and so there was some language put into the CAPTA, the Child Abuse Prevention and Treatment Act, back in 2003 and amended in 2010 and amended again with the CARA Act in 2016. Okay, and what did that language say? Okay, and I'm going to just touch on this briefly because it frames our conversation of why we're here, but why we all have to work together. So what this said is that the states, in order to continue to receive these really important dollars, which may not affect my nursery, but may affect the families that are in my nursery, okay, that the state needs to have policies and procedures in place to address this issue of infants born and identified as affected by substances prenatally. Okay, and originally the language was around prenatal illicit drug exposure, and then it was amended to include fetal alcohol. Okay, and it was said including a requirement that healthcare providers involved in the delivery of the care of those infants, or delivery or care of the infants, notify Child Protective Services. Okay, and that there would be some sort of plan for safe care. Okay, so this plan of safe care is why we're here today. And when I heard this as a pretty naive pediatrician, I said, well, wait a second. Isn't that kind of our job in the healthcare setting? And so child welfare is being held to an expectation that really is largely what we're doing in the medical piece, or we're in part doing. So when this happened, when CAPTA reauthorization first passed, the Children's Bureau, so the organization federally that tries to assist with a lot of these issues, basically said, you know what, we have no clue how to do this. I shouldn't say that, that's totally unfair. They said, this is a challenging issue, which is why we're all here, and we need your help. And so they put out an RFP, and I was at the time at Denver Health as a child abuse pediatrician, and they said, you know what, this was in '05, they said, would anybody out there like to apply for some funding to try to figure out how to do this, okay? And so, again, very naive, we put in an RFP, and so we, meaning myself with Denver Health and Denver Human Services in partnership with the Kemp Center and some of our research colleagues there, and we put in this RFP, and what we did is we along with 3 other sites, were funded to try to tackle this really complex issue. And what we did in Denver is we basically said there was a couple things that really bothered us. Number one was this didn't talk about pregnant women. This talked about babies once they were born. And we all really struggle with, well, what if we got to them before they were actually born? I mean, in my work, I said something about a child abuse pediatrician, but if I could be out of business someday because we do a really good job of identifying which families are at risk, and one of those categories is someone who's struggling with substance use disorder, someone who's struggling with mental illness, okay? If we can identify that family and get services to them prior to a child welfare situation, wouldn't that be great? Because then I would just retire and go do something really, something else, right? So what we said is, number one, we worried about pregnant women, but child welfare's hands are a bit tied, right? Unless there's other kids in the home. You guys can't jump in and swoop in and sort of become involved in a family when mom's pregnant and there's no other kids, or there's other kids and there's no other concern. So we thought everybody, child welfare was worried. They said we would love to have an influence before the baby's even born. And then there were other issues that came up for us, because this is prior to alcohol being added, was that we were worried about families struggling with alcohol disorder, okay, alcohol use disorder, not just illicit substances. So we, along with 3 other sites, put together our project, and we learned a lot of things, and we established an advisory board, and we had a lot of partnerships along the way. And as many things happened, the funding ended. We published a paper, which is really interesting, because I'm going to read you one of the recommendations that came out of the paper. And this was published in, when was this?
2010.
2010, thank you. One of the recommendations said all parties must be involved in the development of a plan of safe care so that services are coordinated and realistic rather than contradictory, duplicative, and overwhelming for families. That's why we're here. Okay, and so we put this paper together, and we said we have this really fabulous advisory board, and we didn't want it to go away once the grant went away. And so when Jade and I started working together on this, we said, well, why don't we tuck it away in this state effort that she talked about, and sit it within the Attorney General's office. Like, we thought that would be pretty good. Like, let's solidly sit it there, and then it's going to be hard for people to take it away, right? We held a summit in 2009, so 9/9/09. That's why you always remember that date, right? Yeah. We held a summit, and we said, all right, let's pull folks together. Let's really have a conversation to begin to address this issue in a larger group, much like this. We held it in Westminster, and we had discussion around privacy and prevention and prosecution and protection. Sound familiar? Some of the challenges we all struggle with, right? And that resulted in our formal steering committee being established. We then, go ahead. Okay, because I said, jump in. Then we put together this white paper. So the work of what we learned from our group, the work of that we started collaborating on, we said, let's kind of codify that in something that at least is tangible, something that we could get to people and we could start giving you all some tools on which to build. Another thing that happened is early on, what we heard is this whole idea of how do we identify these families as early as possible. We heard a lot, now this might be shocking to some of you, okay, not. How many people would have worries that if I identify someone at risk and I call that out and I either test them or I have them tell me that they're using substances while they're pregnant, they may be at risk of being criminally prosecuted, or they may be at risk of losing their kids? Anybody ever had that thought or that concern? Okay, we heard that from a lot of our prenatal providers. And so we went back to our task force and we said, well, hey, folks, this is what we're hearing. And we're hearing that a lot of prenatal providers might be really nervous about identifying these situations because they're afraid that they're going to get mom in trouble or they're going to lose them as a patient. And at least they're there getting prenatal care, right? So we went to our task force, and even our district attorneys that were involved, and our attorney general said, well, we don't want to put women in jail if what they really need is prenatal care. We said, great, let's get it in law, right? And that's what we did. And so we put it in statute that said if someone's seeking prenatal care or identifying a pregnancy, if they are tested or they disclose their substance use to their provider, that cannot be used in and of itself to prosecute them. Now, what about child welfare action? That's what the next thing that came up. A lot of people said, well, what about child welfare? And we had to recognize and acknowledge that if there are other children in the home and there's a safety issue, we can't necessarily step in the way of that. But we certainly can set the stage for this being a more partnership process and helping folks get the services that they need rather than being prosecuted.
And I'll add that we were one of the first states in the nation to put this protection in place for families, and it did pass unanimously in 2012 through our state House of Representatives and Senate.
So the power of really all of us coming to a group and to this really wide-ranging task force and saying, how about we do this, and being able to move it forward. And part of why we say this is so that you're aware of this, if you weren't. Part of why we say this is the power of what we can achieve together, is moving these kinds of things forward in a way that helps us think very differently and really serves families and kids. So after that, then this is when Jade and I had a lot of fun. We went a lot of places together. You were pregnant with Brielle at the time.
Yep.
And we actually, and I know she probably laughs that I tell this story, but we would, at different stages in the pregnancy, we'd say, all right, she's now this big, right? And framing our conversation about how these are such important conversations for this little growing being within Jade or within other women that are parenting. Now, Jade wasn't using substances because I watched her like a hawk. No, I'm just kidding. But
I wouldn't even eat the lunch meat.
She was, yeah, exactly. Which actually is a really important thing to say, right? Because the reality is that someone who is struggling with substance use disorder, it's not like they want to harm their baby, right? And I don't have to tell some of you this. Maybe others might have I think it's harder, right? The reality is that most women who are pregnant will do anything and everything, including not eat lunch meat, if they can help it, right? And so really changing the paradigm. So when we did that trip, that was when we really got some great insight from a lot of people, and thinking about that circle, being a circle of the different points of intervention rather than a linear component, okay?
And she was a lime when we started and a melon when we ended.
That's right. And she's now how old?
6.5.
And quite a voice within your world, right? So one of the other things that happened is, based on our convenings, we were actually listed as a case study in the Association of State and Territory Health Officials in 2014, which is a really cool thing. Again, trying to underscore the power you all in this room have here, and all of us working together, and what we can achieve in terms of really changing a paradigm here. Go ahead. Yeah, this is you now.
So through all of this, through our white paper and the legislative process we went through the regional convenings, the write-up, we got a lot of clarity that there was a huge opportunity point that we weren't quite yet maximizing at the point of birth. And really the interaction between our hospital systems and our community-based systems. And so in 2015, which was right around the time that CAPTA was reauthorized, so the CARA, which was the Comprehensive Addiction and Recovery Act of 2016, was really when the federal government reauthorized CAPTA and said, but we really mean it about those plans of safe care. Like, you really need to actually create these plans of safe care, track them, and tell us what they mean. And so that was, the timing was right around the same as we said, look, there's an opportunity here. And so we formed a hospital learning collaborative, which was 8 hospitals across 5 health systems. And I know we've got some folks in here that were some of our kind of first participators in that work. And we came together over the period of about a year and a half, and we did an echo series, we did some education, and really we talked about what would it take to start to shift practice, and what are the barriers we're facing, and how do we start to kind of deepen our collaborative work around this issue. And that really led to the new structure that we have for our steering committee and much of the work that we're doing. So some of you may have participated in the Substance Exposed Newborn Summit we held back in November of 2018. When we did that, we launched this new structure and really created these work groups that could dig much deeper into the work. And to just give you a sense, I'm going to run through the projects of each of the work groups to really share what the work looks like today. So Dr. Wells just shared for us kind of the path to today, and now I'm going to share with you where we're at today and the opportunities before we kind of turn it over to other folks to start deepening into the plans of safe care and opportunities in front of us. So a really critical part of our work is a family advisory board. And the family advisory board was formed more recently, but we as a steering committee felt it was really critical that we began to lift up family voice and to hear from families that are affected by the work that we're doing and that are affected by prenatal substance exposure or caring for substance exposed newborns, really had an opportunity to engage in the work and to really influence and inform our practice. So we formed our family advisory board. We had great partners from both our chosen hospitals as well as Mile High Behavioral Health and others in recruiting families to participate in this work. And the voices that we have brought to the table has been really powerful, and I think at times surprising. We brought to them the mission and the vision of the steering committee, and we were thinking we've been doing this for 12 years, like we have a really good sense of the work that we're doing, and what came back to us was a completely rewritten mission and vision statement, and all of the intent was the same, but the words were different. And I think it was just a really kind of powerful moment for us of remembering that words are important and thinking about how we're talking about this and why we're doing this work, and at every turn looking to decrease stigma and increase engagement of families and their ownership of their lives was really is really a big part of the work that we're doing. And so our family advisory board is deeply engaged in really informing and advising on many of the pieces of the following work groups that I'm going to go through. So Chosen, the Hospital Learning Collaborative, kind of morphed and was able to partner with a quality improvement collaborative based out of the university that is the Colorado Hospital Substance Exposed Newborns Collaborative, Chosen. And you're going to hear much more about that from Dr. Smith next. So I'm not going to spend time here other than to say that hospital-based work continues to be a key component of the steering committee and the work that was started back in 2008 and has now continued and morphed into an even bigger, more powerful collaborative. So there are currently, I think we're over 18-ish to 20 hospitals in Colorado that are participating, and then we're also expanding into the Rocky Mountain region, but really a deep focus on how do we improve practice at time of discharge or time of birth of babies. The next one is our SEND Provider Education Work Group. So the Provider Education Work Group was really designed to look at what is the opportunity to expand access to all of the knowledge that's out there. So, we were hearing from a lot of our partners, and providers here are both medical providers, but also kind of community providers. We were hearing that, you can go and Google, and kind of to Lucinda's point this morning, depending on what you Google, you could get a whole different range of resources around how to best support or treat or respond to prenatal substance exposure. And there are definitely guidelines that have been established by many of our associations. So ACOG has guidelines and AAP has guidelines, but those can be really tricky to find. And so one of the things that the Provider Education Work Group was tasked with some support from the Colorado Department of Public Health and Environment, is putting together a toolkit. So it's really a one-stop shop on the Chosen Collaborative website to be able to go in and find whatever resource you're looking for, coordinated and organized to help influence practice. So if you're looking for something on, a patient education material on breastfeeding, then you can go in and find that right in there, and it'll provide you with all sorts of different resources as a provider to share with families or to use yourself to influence your practice. The Data and Research Work Group. So originally we just felt like we needed to get our heads around what is the data telling us? What is the scope of substance exposure in Colorado? And we do have some of these materials is available over here, as well as a whole lot more. So there's lots of materials on this table over here. But really to just start with getting our head around the scope. And that's more complicated than you'd think. And it's one of the things that Kathi and I frequently speak about is, it's really difficult with the data collection we have currently. It's either, self-report data, or potentially we might have some data on like hospital diagnosis codes, but none of those necessarily capture the whole picture of prenatal substance exposure because there's a lot of variation in who's tested or how families share their substance use. And so we have also now committed to really start to understand not just what is the scope, but what does the data tell us about what is our most effective opportunity to prevent or intervene with families. So we're working with the University of Denver and the Colorado Evaluation and Action Lab on a data linkage project to identify opportunity points to best support families in improving outcomes. We have a policy work group. So Dr. Wells mentioned one of our first policies was back in 2012. The policy work group works on a variety of issues really around decreasing stigma, increasing access to resources, including treatment, ensuring families and children receive the support that they need. A couple of things that have been included in that are the data linkage project I was just mentioned that was part of Senate Bill 228 last year to ensure that we have a good understanding of how families are engaging with the system and what's effective. Last year also passed House Bill 1911-93, which is around increasing access to treatment. You'll hear more about the Special Connections program this afternoon. And then House Bill 1193 was strong support. This was another one that passed unanimously. So I think, again, just kind of coming to the understanding that here in Colorado, we really are dedicated to how do we organize to support families in this time period. And when we are coordinating and working together, we can have some really powerful outcomes. The current thing that we're working on is a revision to the Children's Code. So currently, the Children's Code, which is the piece of law that dictates child welfare and child welfare involvement. Currently, the Children's Code says if a child tests positive at birth for a Schedule I or Schedule II substance, unless taken as prescribed, it is child abuse. So those of you that work in kind of counties or human services, that definition is applied, can look really different in different counties. And so one of the things that we've been working to do over the last, probably 8 years, is to come up with language for our Children's Code that is more able to be responsive to the reality of what's happening in families and not based solely on that positive test. Those of you in the hospital systems might be able to connect with the idea or react to the idea of how families are tested, which families are tested, what that testing process looks like, and that there's not always a ton of consistency or structure to that. It can be really provider dependent, it can be symptom dependent. And so really what we're looking to do is have less of a dependence on a positive test at birth and more of a holistic view of how a family is impacted so that the child welfare system is able to engage appropriately rather than, very black and white based on a chemical test that may or may not tell us the whole story. So that is actually currently in the process. It's a part of the Opioid Study Committee's recovery bill this year and is made it through one committee and is sitting in appropriations. If anybody is a big policy wonk and would like to connect with us, we'd love to tell you how to engage in this because we think that this is a critical barrier for families in being able to access the services they need. And it comes back to the worry that Dr. Wells mentioned earlier, which is the child welfare system is a fear for families at times. And so how do we begin to try and step back from that fear-based relationship and really be able to have a system that allows us to engage holistically and meaningfully with families? And you all are already doing that beautifully. We just need our state law to support that practice. We have an FASD identification work group, as Dr. Wells mentioned earlier, we know that alcohol is, by research, one of the most damaging substances to use during pregnancy. It's also really complicated with the legality issues. A recent study indicated that 1 in 20 first graders has a fetal alcohol spectrum disorder that's not diagnosed. So that's about 1 kid in every class, if not more. So really looking at how do we do a better job in both prevention, but also identification, diagnosis, and support for these kiddos. So these were the recommendations that have come out of our fetal alcohol spectrum disorder work group and the needs assessment, and now we're in the midst of a roadshow. They were in Pueblo last week, sharing these recommendations and getting feedback from families and community members to help refine these. Finally is the Plans of Safe Care work group. So chaired by Matt Holtman, now Susie Morris, and one of the chosen hospital docs. There was a lot of work that was done to create the Plan of Safe Care discharge guidelines and checklist to really start to eliminate or to really speak to some of the concerns that Kathi identified back in 2010 of how do we ensure that these plans are coordinated and meaningful and realistic for families. And so there's been a lot of work done around starting to put these together that has led us to be here with you all today. So that's the final work group, and is continuing to work on dissemination and ongoing technical assistance. So Kathi, anything you'd kind of add to wrap us?
No, just how excited we are to have all of you here to sort of roll up your sleeves and help us think about this work together and collaboratively. I mean, as Jade had said several times when she talked, the ability to sort of reach out and think beyond the lens we have. And part of my sort of wanting to show, you all to show the diversity of who we have here, we also have different lenses. And it's okay to acknowledge that the lens we come from might feel contradictory to another lens, but really at the end of the day, we all want to achieve the same thing. So this is our opportunity to think about seeing things through a different lens. And you said it so well with the family voice. There have been many times that I know I've said things that I had no idea were maybe hurtful or offensive, and certainly was not my intent. But until we're open to hearing things in a little bit of a different way, then we can actually, we can create barriers rather than create bridges. And so we're just excited to roll this out and to spend the day with you and to hear more about what your thoughts are in terms of how we do this more collectively.